Hey everyone, this is Victor from Cyborg for Life, and I want to welcome you to episode 120 of Limb Lengthening Live, where the patients get to interview the guests. And today we have a fan favorite surgeon, one of my favorite surgeons in the world, joining us, Dr. Craig Robbins from the Paley Orthopedic and Spine Institute. What's up, Dr. Robbins?
Life is good. Life is good. You look so good with your haircut, I had to match you.
I see that. The short haircut is in. What can we say? Oh,
cool.
Man. I love it. All righty. So, guys, we're starting the stream a little early today because Dr. Robbins was able to break away from work a little early today. So, for that rare occurrence, you get him for a little bit longer today. So, the way we're going to run the show today is we have some submitted questions. Okay. So, we're going to go through those first. And then anybody in the chat that wants to ask questions. But I'm also going to post the join link. So, if you want to just come on the panel and vocally ask Dr. Robbins your question live, feel free to do that as well. Okay. So, let me just go ahead and share my screen. I have a document. And we're going to go ahead and go through those questions right now. So here it is. All right, Dr.
And our disclaimer, because I get nervous now, right? So I'm just a guy. I have some experience. I love to teach. I love to talk. Victor's a great question asker. So I am not assuming care. I am not your surgeon or your child surgeon, but I'm happy to give you my thoughts in this generic conversation. And obviously, if you want to take this more personal, Victor can share my email with you, and you know, I'm happy to discuss. We are set up to do virtual visits and virtual consultations formally if it comes to that, but I'm happy to give you my thoughts, all things being equal. So that's my disclaimer, whatever that means. So
I love it.
I'm going to put glasses on for this.
That's right. And I also have a medical disclaimer in the description below this video, so feel free to read that at your own discretion. All right, so we're going to start this. Question one we have from patient X. I'm going to blow this up here. So he's basically saying, I have x-rays of my tibia attached, and I'll bring them up in a second. But he basically said that my surgeon removed a segment of my fibulas. This is for stature lengthening of the tibias, saying that it would have healed faster than the tibia and caused a deformity. However, it seems like it's not healing now, perhaps a non-union. Is this common practice in tibial lengthening, and what are the effects of having a gap in the fibula? Is it important for ankle stability long-term? And also, what are the potential ways to fix this? And while you're answering that, I'll go ahead and bring up his x-ray.
Sure.
Let's get it here. Let me just blow it up.
There's a lot of questions in there. Oh, Victor froze.
Are we still live?
Okay. Yeah, I hear you.
Oh, it froze for a second? Sorry about that.
Yeah.
Okay. Can you still see me?
Crazy. Okay. Yeah, I see you. I don't see x-rays.
I think it was because I was trying.
Well, while you're pulling up the x-rays,
bring it up right here. Hold on,
do you want me to talk over while you're pulling them up, or does that mess you up? Okay. So interesting. Okay. So first of all, we don't take a segment of fibula out. Yes, it is true. The fibula bone can heal at a different rate than the tibia bone. And if the fibula bone heals too fast, that can be a cause for pulling things into valgus. The reason why is there's more muscle mass on the outside part of the leg. So if things get tight or they're just from the muscle mass, it can pull into valgus. So I understand the concept. If you take a piece out, then it can't heal too fast, and then it is less of a chance to pull into valgus. But it's not just the bone or the bone healing that pulls it into valgus. It's also all the muscle mass over there. We don't take a segment out, and our rate of fibula healing faster than the tibia, it's not zero, but it's really, really low. And it's probably lower than the chance of having two non-unions like you're about to have in this one patient. So, cautionary tale, if I saw this, maybe this is the only two non or delayed unions the surgeons had in a series of 400. It's just unfortunate they're both in the same patient. Now, that being said, where they cut, I don't expect it to actually have any problems in the ankle at all. It would be nice to see the bottom of the x-ray to see if they put distal screws to stabilize the tib fib joint, because that's more important. If that's there and the fibula has not migrated between that stabilization and the interosseous membrane, fortunately, I don't think the fibula is going to migrate up. Now, I suppose it can, and that may be a reason to keep those screws at the ankle for even longer. But in non-stature world, in reconstruction world, there's a series of surgeries done where an entire segment of the fibula. Oh, here's Marshall. An entire segment.
This is the guys. Marshall.
So yeah, here's Marshall. An entire segment of the an entire segment of the fibula. I'm not walking right now. I'm busy.
Marshall is talking.
Yeah. Sorry, an entire segment of the fibula can be removed, and that's actually attached to different parts of the body to bring blood and bone and healing, and it's left vacant, and by and large, those patients do very well, and it's a much larger segment, and it goes closer to the knee and further from the ankle. So so for you, what can be done for this? So that's a big gap. I mean, maybe over time that's going to heal, but first of all, you don't do surgery unless it's needed. So just because the x-ray has a gap, we treat people and humans, not x-rays. If you are asymptomatic from this, then there's no treatment needed. If it becomes bothersome, and that's a generic term, pain in your ankle, pain in your knee, pain there, pain when you're wearing ski boots, because that's kind of where they end or something like that. For a segment like that, for non-union, there's lots of options, but probably surgical.
Gotcha.
So I hope that answered. There were a lot of questions in there.
Yeah, let's get.
So again, this brings to the point. It'd be interesting to know what the tibia bone healing looked like along the way, because maybe they could have slowed the tibia lengthening to give the fibula time to catch up. It would also be interesting to know how they took the segment out. If they used a fast oscillating saw that makes a lot of heat that burns the bone ends. Did they repair the periosteum? There's other surgical technique considerations. So I guess my question would be, if someone's going to a surgeon who does it this way, to ask them, how many of these have you done? Can you show me an example what it looks like? If you have a mal or non-union, what do you do for it? It's a little late to ask the questions now, but I can't predict that this will be symptomatic. I can only predict that there's a gap there on the x-ray that'll be there for a while at least, but maybe it'll fill in.
Okay. Gotcha. All right. And then, let me get back to this here. I'm going to share back on the question screen. Let me pull it up. So he had a few more questions about it.
Sure.
Here we are. So the second question was, we answered that. So this is about the IT band. Will it grow back after being released? Also, if he had to get the IT band released mid-lengthening, will it have any effects on him long-term? Also, how much of the IT band do you typically release in your practice, both proximally and distally?
Great question. So all things being equal, any elective femur stature lengthening at our practice is having a distal iliotibial band release. We do it through about a 3 or 4 centimeter incision on the outside of the leg by the knee, and the iliotibial band is like a sheet of paper. So it's maybe down by the knee, maybe it's this wide. Paper thin, it's actually thinner than the stacked paper. And paper like this is incredibly strong. I can rip it this way pretty easily, but it's very strong. And the fascia, the tensor fascia lata is just like that. So we actually transect it from top to bottom, front to back, however you want to describe it. And it makes a little bit of gap, but shockingly, by the time your lengthening is done, it's almost completely grown back. I mean, it takes time for the collagen fibers to realign and to form back, but your IT band can get tight again by the end of lengthening. So if you're in a place where either the surgeon didn't feel you needed it released at the beginning, okay, we choose to, but then you can do it mid-lengthening, and I think it will help you greatly. I think you'll be very relieved. And releasing it at the knee does have a little bit of effect at the hip, but about 5 or 10% of our patients on the front end are just inherently tight, and they get the release proximally as well. That's not all of a sudden done on every one of our patients. It's we assess you before surgery, and it may only be about 5 or 10% of the time people need that. And because we wait for your bones and for you to recover as much as you can, ideally back to normal, before we even talk about removing the rods, even if you leave tight, which almost everybody does, our institute, you leave with an exercise program, and you leave knowing that you're going to stretch out these things. But if you come to us a year and a half after your surgery and you're still tight and you've plateaued with your therapy and it can't get any better, well, then you've had a chance to get it as good as you can get it. Maybe you would benefit from soft tissue release. So Sometimes people ask, hey, my bone is healed 4 months after I finish. Why don't I take out the rods now? And my answer is, if you're fully recovered and don't have contractures, then we can. It's not arbitrary. We say a year. It's because that's about when most people are fully recovered. But if you do a 2 centimeter lengthening and you're fully recovered 7 months later, sure, I'll take the rod out. I don't have to wait a year for any particular reason. It's because I would hate to take it out early, do a soft tissue surgery, and you would have improved anyway 3 months on your own. Why do I need to operate on you? Make more scar tissue, potential complications, though they're rare. You can't have a surgical complication if you don't operate. So we don't take it lightly. We don't do it just because, and I don't think it's going to have effect on you long term because it's going to grow back.
Gotcha.
Okay. So how much do you release distally? We literally release from the front of it to the back, all the way. It's one structure. And proximally, we don't release the whole thing necessarily. So when you get proximal, it's not a thin piece of paper. It kind of folds over on itself, and it has some structure to it. And usually we leave part of the posterior segment attached, but we do what needs to be done to improve your motion. But we don't necessarily release the entire thing proximally at the tensor.
And when you're making that decision to whether or not to release proximally, what do you do, like, before the surgery? Like,
how do we decide?
Yeah.
So when you come to us, if we do a virtual exam with you, then obviously before surgery we have an in-person, because we're not going to operate on you if we haven't examined you. And you kind of have a good feel for when I'm examining you, how tight your hips are, how much motion you have in certain ranges. But so we talk about, hey, you definitely need it. There's no question about it. That's pretty rare, 5% maybe. Or I don't know if you need it, but you may. So we're going to talk about it. And if I think you do, I'm going to do it. Okay, fine, Dr. Robbins, I agree with you. That's fine. So during surgery, we always start at the knee. And sometimes when you do the iliotibial band release only, it releases enough that the hip isn't so tight. And you say, okay, we're not going to do it. Now, maybe I get proven wrong and that person gets tighter and we have to do it midway like this person is, or a year later. But we didn't go rushing in to do a surgery just because we could. We were giving them a chance, and we weigh the decision on each person and on each side. You may be super tight on one side and not on the other. So it's based on the clinical exam, plus how much length you want to get. If you only want to do, and I don't say only 3 or 4 centimeters so flippantly, because you get complications there too. But if you have a shorter lengthening, less chance you're going to get as tight. So if you're borderline, maybe we won't do it, because we could always go back and do it if we needed to. But I hate to do a second surgery if I think you're going to need it. I'll just do it now.
So it's case by case basis.
Yeah.
Gotcha. All righty. All right. So we're going to move on here. So this next one is about a father. I actually talked to this guy in a consultation. He's looking for a leg length discrepancy fixed for his son. So, hi, Dr. Robbins. My son has a leg length discrepancy, and I've been exploring resources on options. I came across something called the multiplier method, and I have a few questions about it. Could you explain what it is, and does it refer to predicting future leg lengths or possibility of multiple surgeries as the child grows? We'll start with that.
I can totally answer that for you. So let's say you brought your son to see me at whatever age. Even shockingly, if a neonatal ultrasound shows your child has a short femur or a short tibia, and it's a good ultrasound taken orthogonally, and we can actually measure the bones, it's very subject to change, but we can make a gross guesstimate of how much leg length discrepancy your child may have at the end of skeletal maturity. When it's that early, 1 millimeter makes a huge difference in the prediction, but still it's possible. So we have a lot of pregnant couples come and something's identified and they just kind of want to understand options. So let's say you bring your son and he's 4 years old and the difference just by eye is about 1 inch or 1.5 inches. Well, here's a quick rule of thumb. If you're 4 years old and a boy, whatever difference you have is about a half what it'll be. So if you have a 1 inch difference at age 4, when you're done growing, it's going to be about 2 inches. And it's the same for girls around age 3. These are very rough, but it gets you in the ballpark. So if your 4-year-old son has a 1 inch difference, it depends on what the cause is. There are different causes that can have more discrepancy, but in the generic sense, a patient with a congenital discrepancy, if you have a 2 inch difference at age 4, it'll be about 4 inches when you're done growing. And there's a lot of information in that statement, which is like this. Your first few years of life are your most rapid growth. If you get half of your adult height by age 4, then it's going to take another 12 years to get the next half of your height. So once you get to that age 3 or 4, boy or girl, the difference increases, but it increases a little bit slower. So yes, I can predict, but guess what? So can you. You can go to the iPod store, the Android store, and you can type in Paley Growth app, and you can download it on your phone. And all you need are a couple things: your kid's birthday and some lengths of the bones. And so you go to congenital discrepancy, or you follow the prompts and you do what you want. So you enter your child's birthday, you enter what the discrepancy is currently, and you push the right button, and it will tell you, if nothing is done, all things being equal, if you show up at 17 or 18 years of age and your son is done growing, the difference you have now should be this. Okay. And it's accurate within a half a centimeter or a centimeter. There are other factors, but that's pretty darn good. I mean, a centimeter or half a centimeter, that's a normal difference. So, so the next question is, does it predict the number of surgeries? No. But with that number, you can now create a surgical reconstructive plan. If your son at age 4 has a 4 centimeter difference, that's about 1.5 inches, then it's going to be about 8 centimeters when they're done. So I would say there are probably 2 surgeries for your child. There's a lengthening about now or sometime in the next year or so. And then there's a lengthening 5 or 6 years later. And then you're done. You do 4 centimeters now, you do 4 centimeters around age 14 or 15, and guess what? You're done. So yes, the prediction, however you do it, whether it's with the multiplier method or other ways, it's to come to that same data point. This is what I have today. This is the age of my child. What is the expected difference going to be? So the multiplier method was developed by Dr. Paley a long time ago. He actually published the paper with one of his children. Who's not a doctor. I don't know if he was in high school or not, but they went and they looked at skeletal data, and they found that regardless of race, geography, era, time, height, century, growth rates are pretty constant. And so whether you are a Caucasian woman born in the 1400s or an African man born in 2023, the rates of growth, now the amount of growth may be different. A person from the European continent, male, may be much taller than a woman born in Central America, but the rates of growth are pretty constant. And that's a pretty cool thing. So multiplier method is an easy thing to do because there's an app, but there are other ways to chart growth that are much more complicated, and your pediatric orthopedic surgeon could do it. There's the Menelaus method, and there's the Green-Anderson method, whatever these methods are, but this is pretty darn accurate, and it's what we use. So what the multiplier is, kind of what I started off at age 4, a boy, the multiplier is 2. So if your difference is 1 inch, you multiply 1 inch by 2, and it becomes 2 inches. Okay. At age 15, the multiplier is probably 0.01, meaning if you have 1 inch, it's going to be like 1.01 inch. It's going to be a very minimal difference towards the end of growth. The multiplier in a neonate is probably 5 or 6 times. So if the difference is this big before you're born, it's going to be 6 times bigger when you're born. So the multiplier quite literally is an age and sex dependent thing. You take the difference and you multiply it by this multiplier. And that's how we predict discrepancy, which goes into your part B. So,
yeah, that's incredible. Wow.
And why that's important is it's nice. So you are pregnant and someone recognizes there's a challenge with your child and they're going to have a difference in their legs, and you're so overwhelmed by having the child. You're so overwhelmed by all the other things too. What are we going to do? His fibula is missing, or whatever it may be. These are huge things. These are huge emotional things. Well, there's resources, and we're one of them, and we do lots of virtual and in person for these things. But your surgeon, if it's us or somebody else, can use that information and make predictions. Now, the more predictions you make over time, the neonatal is one, but then they come at a year or 2 or 3 or 4 years, and we're getting more data to make more data points. And maybe the difference was going to be 9 centimeters, and now it's 7. Great, wonderful. More data equals better, but it still gets you in the ballpark. 7 or 8 centimeters is still probably the same treatment much different than 3 or 4 centimeter difference. So, and your surgeon should be able to make a rough outline, make a rough surgical plan, a reconstructive plan, all things being equal. This is how I see this happening to get your child through skeletal maturity so their legs are even, or whatever the goals are.
Right. And for this guy's specific case, I know that he said that his son had a basketball injury. He fractured his femur distally, and they said that it might have, affected, manipulated the growth plates. And they do have I think it's a mild discrepancy now, but he's about 12, 13, I think. And he's just worried about like what might happen the next year.
Sure. Okay. So that's a much different to this. So you just said everything I said goes out the window. Okay. Everything I was talking about there was a congenital problem. So let's say, but the app still can take care of this. So let's say your son's 12, has a fracture through the growth plate, and we know this growth plate is done. You take an x-ray a month or two later and done. First, you have to track it over time. You should follow up, not just, walk away and wear a shoe lift and come back in 6 years, because what if it's not fully affected? What if it's only partially affected? So instead of growing just length, it may grow into angulation, it may grow into rotation, and it may grow funny. And if a malgrowth is happening, you could do things earlier that are easier than later to try to correct it or arrest it so it doesn't get worse.
Gotcha.
The reality is, however it ends up, there's a reconstructive plan, but it's nicer to intervene earlier if that makes sense. So if your child breaks their leg and growth is absolutely stopped at age 10, making this up, you can go on the app, and instead of congenital, you check the discrepancy and you put in age 10. What is the discrepancy now? And it will tell you, you pick the bone part, the distal femur. This is how much growth you would be expected to have. So at age 10, if it's about a centimeter per year for the next 5 years, that's 2 inches, 5 centimeters. So yes, it can predict that. Now, there's always something else to say. If you break your femur in the middle, not in the growth area, and it overlaps, you're 4 years old and it overlaps a centimeter or two, almost an inch. No one's going to lengthen your kid. No one's putting in a shoe lift for a ½ an inch discrepancy in a 4-year-old. Run, jump, play, heal, recover, because the fracture can actually overgrow. So you may come back 6 months later, the fracture is more than fully healed. They're back to normal. You may come back a year later, and that leg that had an overlap short bone may be a ½ an inch longer than the other leg was. So we don't jump on discrepancies in young kids with trauma, because we can expect some overgrowth. So if you're in my practice and you have a break near the growth plate, either I'm seeing you or telling you go somewhere else, but every couple of months you're checking on the growth plate and the growth, not just longitudinal growth, but making sure you're not growing into an angular deformity, either like flexion or extension or something. And remember, you can also stop growth on the other side. Let's say you're 15 years old, you're still growing, the growth plate is completely hammered for whatever reason. Well, if you made the decision to stop growth on the other leg within the next couple of weeks, you're not going to have any discrepancy. You took out both growth plates on both sides. That's a bad example, but you understand what I'm trying to say.
Right.
So somebody has a tumor, cancer, non-cancer, horrible situation, but they have something affecting their growth plate, and I have to do surgery, and I know we have to sacrifice the growth plate to do what we need to do. Part of the conversation is predicting the growth lost. If it's not much or not bothersome, then we'll just stop growth on the other side at the same time, do it all at once. We know what's going to happen. Why wait till there's a problem? Now we have to treat it. So I've done that more than a handful of times. I'm treating problem on one side, and we always anticipate what are the effects. I say in my practice that in children, we think in 3 dimensions, at least from the bones. What's it top to bottom? What's it front to back? And what's it inside outside? But the 4th dimension is what's going to happen to this child over time, because all children are growing. So I may have the perfect measurements of your child's deformity. It's 6 degrees this, it's 8 degrees that, it's 4 centimeters this. But what's it going to be like in a year or two if I intervene or if I don't intervene or both? So with kids in particular, you always have to consider how this deformity is going to change over time with my intervention or just with normal intervention. Oh, you hush over there. If he keeps acting up, I can bribe him with a peanut butter bone. That gets me about 30 minutes. Okay, so I think we got that. Yeah.
That is a very phenomenal answer. Now I have one question about that. When we talk about like a young, let's say adolescent
Sure.
teen who's
Yep.
growing,
Yep.
and let's say he's not fully, to his stature, that his full
Yep.
grown potential of stature,
Yep.
would you still consider stopping the side that's growing, or
So that's a tough question, because can a 14-year-old understand the process and say, yes, I understand you're going to stop growth and I'm going to be an inch shorter than otherwise would be? Well, first of all, when they're 14, it's not really their decision, it's their parents. It's nice to include people. But I've had more than a handful of people. I'll give you an example. So 12-year-old girl who is 5'8" already, she had a problem with her growth plate, and we predicted she was going to lose a centimeter and a half, which a half an inch is enough difference that's probably going to cause a problem. And the decision was stop growth on the other side. So we stopped growth on the other side and there. Now, what if she were 4'11", had not yet had her menstruation? Then she may have a 2-inch difference. And 2 inches at 4'11" maybe isn't enough height for this child or their family, and maybe they're not going to want to do that. So, and then you have to ask, stopping growth means operating on the leg that's never had a problem. Why would I possibly do that? Everything happened on the right leg. Why don't we just see what happens, wear a shoe lift, and I'll lengthen you for a centimeter and a half to whatever you need. So all of these are great questions. And this is a lot of, your surgeon should know, what are the options if you have a leg length? Do nothing. It's not bad. It's not going to cause problems, leave it alone. It's a 1/4 inch. Who cares? Not really who cares, what I'm saying. You do nothing. That's an option. Option 2, you wear a shoe lift. Fine. I wear a 1/2-inch shoe lift. I'm not pain in my hip, knee, or back, and on with my life and wear shoe lifts forever, and that's great. Option 3, stop growth. Option 4, take away. I could actually take a segment out of the other side if you're not growing anymore. Option 5, I can add length. And all of these things play, and there's no clear-cut guideline. Early in my career, would I have done a lengthening for 2 centimeters? Probably not. Now, absolutely. So maybe I would have pushed for stopping growth or shortening, or whatever the options were. So it's great you're asking these questions, and I just gave you a 2-hour lecture on limb length discrepancy evaluation in about 6 minutes. So I'm sorry I threw so much information at you.
He's going to very much appreciate that, and I mean it does put a lot of pressure on. Yeah, go ahead.
Again, reach out to me. Happy to look at X-rays and set up a consultation and give you my thoughts. Whatever that means.
Absolutely. And I mean, it does put a lot of pressure on the parent, right? Like if they have to make that decision, it's like lengthen, stop, shorten. And it's like, when the kid's not fully grown, it's like, well, and then they might be angry and resent their parents for like that. So
it's interesting. So, my heart is with kids. I treat lots of adults. Today, I took out hardware that was placed in a 6-year-old child. Oh, but it was 76 years ago.
What?
I took hardware out of a guy's hip today. My partner was doing a hip replacement. So I excavated hardware that had been in this guy's leg for 76 years.
I can't believe that.
I love it. So it's funny. I cleaned the plate. I gave it to his wife. She started crying. Oh my God. The screws were like Phillips head and slot heads. Like this was like a 2-hour excavation to get this stuff out. But if there's broken screws blocking the canal, you can't put the hip replacement in. So my partner's like, help. And I said, happy to do it. So we worked together, and it looks great.
Talk about a souvenir. Oh my gosh.
Right? A screw veneer. Yeah. So anyway, so obviously my heart's with kids. I do adults too. But I'm a dad, and a lot of people say, Dr. Robbins, you're a father. What would you do if this were your kid? And I think that's a fair question. And obviously, all circumstances and situations are different. There's cultural things, there's financial things, there's social things, whatever they may be. But I'm happy to tell you what I think I would do. But the reality is, I don't know. My son doesn't have this problem, but this is how I would think it through. At least if I could try to take some of the emotion and try to be rational. But a lot of families do. I'm talking so fast, they get so excited. I'm sorry. A lot of families do try to include their child in the decision making. Now, if your child is 2.5 years old and they're predicted to have this gigantic discrepancy, maybe it's not prudent to wait till they're 16 to ask them, because you've lost 14 years of potential reconstruction. And those are the hard ones. Sometimes the decision is amputation or reconstruction. Holy cow, could you imagine being faced with that situation? Gosh, these parents are so darn tough. It is unbelievable, the decisions they have to make and the sacrifices they have to make. Not just financial, personal and social, and their own personal growth and career advancement, all of these things. But, you know, we make the decision to have parents. We hope these things, to be parents. We hope we never have to make these decisions, but it's kind of part of the territory. We are responsible for these little human beings through adulthood. Gosh, I'm going to go on tangents.
No, that's fantastic. Yeah. I mean, and I could feel his struggle, his internal strife when I was talking to him on the consultation over the weekend, and it's like, I feel for you. But no, that was fantastic advice, and I'll make sure to point your answer.
There is a solution. That's the good news. Let's take it home and make it happy. Whatever this difference is, there's a solution, whether it's surgical or not. And don't lose heart. I promise somebody can help take care of this, whether it's me or one of my partners or someone close to home. And I'm happy to give you more information.
Very cool. Awesome. So he can reach out. All right. So we have this next question here. They're basically saying, oops, sorry.
Yep,
Let me make,
I see.
You see it.
Yeah.
So I have a G6 PD deficiency, being anemia, and is lengthening surgery safe for him?
Yeah, it is. So it's good to know that you have it, because there's certain indications and contraindications with medications and things like that. But yes, in a very general sense, yes. I'm guessing they're from Europe somewhere. The Mediterranean, I think, is where they have a lot of that. But pardon me one sec. My wife says, I've been craving lentil soup. I finished your Alfredo for lunch. All right. I like to cook for my wife, so I'm going to make my wife lentil soup tonight. Red lentils.
Come back to your house and you cook for those lobsters are amazing.
With paprika and onions and garlic. I can already smell it. The house is going to be so great.
I'm going to register for the next Beat Bobby Flay.
You what? You what?
Register for the next Beat Bobby Flay episode.
That right.
All right. Let's see here. So this next question is like a multi-part question. So this is actually from Nailed Legs. He actually just did a presentation that I featured him on my channel. And basically he's saying, Dr. Robbins, there are some people on the limb lengthening forums that believe that an external fixator for the tibias with no internal nail, not an LON, just external frames, are the safest way to do limb lengthening. This idea is primarily due to their belief that, true or not, you can reduce the chance of fat embolisms due to the bone not needing to be reamed. 2, there's less soft tissues in the tibia versus the femur being cut, with the pins. It's less traumatic for the body to go through the. So let's start with that. So number one.
So I'm going to pause for a second. I'm going to peanut butter bone for Marshall. And that'll buy us about 30 minutes.
Awesome. Sounds good.
Marshall, where's your bone, baby?
All right, guys. So we have Dr. Robbins live, Dr. Craig Robbins. So make sure to put all your questions in the chat, or feel free to click on the link in the description or in the chat to come on stream. I know we have one guy here, but he has seemed to leave. But feel free to come on and ask Dr. Robbins your questions live. But we're going to go through this document first because these are the submitted questions, and then we'll take questions from the chat or whoever's on the panel. So don't be shy. This is your chance to ask surgeons questions. So feel free to join. I see plenty of questions in the chat here, so we will have a good, oh, okay, so here we go. This is your question. We just answered that, so you are good to go, Dr. Robbins said. So, but obviously check with your doctor, because medical disclaimer and all that fun stuff.
Okay, I'm back.
All right, we're back.
We got Marshall with his Kong and kisses with her bone with peanut butter on both ends. Okay, so this is great. I love this. So let's take it from the top. The internal lengthening nails in general, very broad sense, were developed to be the next generation to kind of get away from external fixators. Why are we getting away from external fixators? They've been around for over 100 years. They've been codified and studied, and everybody knows how they work, and they work great. But they have challenges. They have pins and wires that enter the skin and enter the bone. And as things are moving, those pins and wires can irritate tissues and create scars and infections and complications. And how do you wear clothes? And they inhibit joint mobility and all these things. But they work. They're great. And if you had to pick above the knee external fixator or below the knee external fixator, 100%, it's easier below the knee. Now, just because it's easier doesn't mean it's better. So let's look at the questions you ask. So yes, it is true. If you don't ream the bone, which is how we hollow the bone to make room for the nail, then that will lower the chance of fat embolism. So what is the risk of fat embolism? What is the risk of fat embolism becoming fat embolism syndrome? What is the risk of fatality from fat embolism syndrome? These are very scary things. Fat embolism and fat embolism syndrome are quite literally life-threatening. And they have nothing to do with stature surgery. They have to do with broken bones and hollowing bones and things like that. So the fat embolism syndrome was probably discovered or described not hundreds of years ago, probably 100 years ago. It's this polytrauma. Someone is crushed, run over by a buggy, kicked by a horse, and whatever it was. Multiple broken bones, not necessarily reamed, multiple broken bones, release their contents into the bloodstream. Bone marrow is inside the bone. The bone marrow has fat. It goes into the bloodstream. The blood is filtered, goes through the heart, filtered through the lungs, goes back to the heart, goes to the rest of the body. So, one of my children's about to walk in the door. Hey, son, I'm on a Facebook Live, so come in quiet.
What's up, Oliver?
That's Oliver, yeah.
That's Oliver.
We'll brag on Oliver later, who's about to sign a football scholarship as a kicker.
Are you kidding me?
Yeah, no, I'm so excited. Like I can't.
Wow, that's huge. Congrats, Oliver.
Yeah, it's cool. So fat embolism and fat embolism syndrome can happen without your bone being hollowed, but we believe when the bone is broken and then it's hollowed, that can potentially increase the risk. So yes, in a very general sense, it is safer to use a fixator if your risk is fat embolism. But what's more common, fat embolism or fat embolism syndrome, or a pin or wire infection, or problems with the soft tissues because of the fixator pins? So all things being equal, there are probably more complications, probably not fatal, like fat embolism, with an external fixator than a nail. Now, if you came to me, I have to be careful what I'm about to say. If you came to me and said, Dr. Robbins, I want to be lengthened, but I don't want to use a nail, I want to use an external fixator, that's a legitimate conversation. You have to consider what the scarring is going to look like, because for someone who's coming to me with that, hey, Blake, I'm on a Facebook Live. So, yeah. So if someone's coming for the cosmetic aspect, I want to be taller, then they're probably concerned about the aesthetics, and the scarring from the pins and the fixator are more than with an internal nail. So those are real considerations. Now, our practice, and I hope every practice would say the same thing: safety, safety, safety. The fact that we know fat embolism and fat embolism syndrome exist means we do things during our surgery, our techniques, to try to mitigate against it. Our anesthesiologists are where it exists, and they do things when we're operating to try to mitigate against it. And we look for it really closely in the perioperative period. And if we think it's happening, we jump aggressively to treat it. So all that being said, our rate is very, very, very low. Fortunately, we have not had any fatalities. And that's not just our stature practice, which is a small part of our entire practice. In the hundreds and hundreds of osteotomies performed at our institute, to my knowledge, we don't have anyone who's unfortunately expired from fat embolism syndrome. And that's many thousands of osteotomies over the last years and years and years. So thankfully, it hasn't happened. So did I answer that?
Yes,
so
yes, you answered
a fair question and a fair discussion, but it seems more theoretical. But okay. Okay, there are less soft tissues in the tibia versus the femur. Is less traumatic for. I don't know about that. So there are some description in the literature, particularly in the trauma literature, because there's many more nails put in tibias for broken bones by accidents than broken bones by surgeons, whether it's a corrective osteotomy or stature lengthening. And so there are descriptions of pain in the knee. There's knee pain from the heart. Our incidence of knee pain, there's lots of things that get sore and hurt from lengthening and tight and things like that. But I can't think of someone who, after the surgery pain's gone away and they've back to recovery, is having pain in their knee because of the technique we use. It's a small little incision. We don't go through the kneecap. We don't go through the tendon. We do it the same way every time. And our incidence of knee pain or knee problems after the surgery and recovery, I can't think of one. I'm sure there is, but it's incredibly, incredibly low. So to say it's less traumatic to go through a nail, I mean, how do you define that? Is it less traumatic for me to take a drill and drill 6 holes and have metal pins sticking out of your leg for 6 months? That's kind of traumatic. It's traumatic to look at. That being said, I love fixators. I mean, I love putting fixators on. Fixators are amazing because they give you such versatility. Now, if you said to me, and I've had this happen. I had a patient who had very bad Blount's disease. So it means their knees were very bowed and they had some rotation. And they had some angulation. So they had a multiplanar deformity. Could I have corrected all of that and put a nail in and added length at the same time? I could have. But once you get to that many deformities, and this guy was a physician and wanted to get back to work quick and be able to walk without being on crutches. So at the time, there was no weight-bearing alternative. And just in his scenario, we went for fixators. So I used the fixator and he went back to work and he's walking on it. And we corrected the rotation and the angulation. And maybe we added a couple of extra centimeter or so because we were there with the fixator. And anyway, but fixators have an absolute role. But for a single deformity, lengthening, axial lengthening, it's a consideration. But we worked hard, especially Dr. Paley, who helped design it and develop it, to develop these nails to get away from the fixator.
Mm-hmm. Yeah, absolutely. Then his last point here was basically saying, are the risk of fat embolisms with internal nails versus external tibias or frames really that much higher? If so, what's the increased incidence rate? Is it fair to say that external frames for tibias are safer than the precise nail on your femur?
We're splitting hairs for our incidence and our rates of these problems are so incredibly low. Our numbers are not 0, but they're pretty darn close. So they're both safe. And if I'm correct in my memory, our 2 patients who had fat embolism syndrome were both during COVID, both had exposure to vaping, and both were femurs. So how about that?
Wow.
So it's a great question. It's an intelligent question. Other people may have different experience. Maybe their technique is different, so they have a higher rate, or they've had, God, I hate to say this, may have had a fatality, but they can happen from limb reconstruction, not just surgical lengthening. It's real, but knowing it exists, your treating team, is probably the biggest thing, because if you're not aware it's happening, and a few hours after surgery, you're having problems with oxygenation, and someone's trying to play catch up to figure out what the problem is, then you're really in trouble. So being in an experienced center is so important, and making sure your surgeons know how to help prevent and recognize problems and treat them aggressively. So
yeah, absolutely. And then, if we were to have the discussion of, let's say, internal nail versus lengthening over nail for stature lengthening, that's a whole nother discussion. But I think then internals by themselves.
That's a cost thing. Yeah, I think if we just had to distill that down, I think it's a cost thing and an availability thing. I think if those surgeons had a weight-bearing nail, they would be doing it weight-bearing nail, is my guess. Can't speak for them. But it's cheaper, and if you don't have it, you can't do it if you don't have it. It's probably nicer for the patient because they get out of the fixator faster, right? So the idea is you put a rod in, you put a fixator on, you cut the bone, and you lengthen over the rod. And once you get to length, you put screws in the rod, and then you take the fixator off. Look, we've just kind of proven the point. We're trying to get out of the fixator. So you're getting out of the fixator faster if you do the lengthening over the nail in theory.
But real quick, is there more risk for deformity when you're lengthening over nail if the surgeon doesn't have good enough experience, than just using an internal nail?
It's a great question. So what if you're developing deformity with a fixator and a nail? Well, you have a fixator. It's like the ultimate deformity correcting tool. Adjust your fixator, correct the deformity.
Yeah.
Even with the nail in place, it may be a little harder to do, but you're not going to get, the nail precludes certain deformities. With the nail in place blocking the canal, you're not going to get a translation of 3 centimeters because the nail will block that. But maybe you get a little bit of varus or valgus. So adjust the fixator, which you could probably do in clinic, to
Yeah.
correct the deformity, maybe even add length. So you do like cool Elizarov stuff, or you turn it into a hexapod, whatever you want to do. You may have to go back to the operating room to add blocking screws or some technical stuff. But the fixator is the ultimate deformity tool. So developing a deformity with the fixator on, it's like, what are you doing? It shouldn't happen. And then again, I'm making light of this, but just because your goal before surgery is to have the fixator on for lengthening only 2 months, and then lock the nail and get the fixator off. If there's a problem happening, reassess, and maybe the goal has to change. I'm sorry, things didn't go as expected. We're having this problem, and here's a solution. We're going to adjust the fixator. We're going to leave it on longer so you don't have problem XYZ. And we are adapting to the situation. We're recognizing a problem. We're not just going to say, well, 3 months ago, I told you I was going to take it off, so let's take it off, and your leg's crooked. We'll deal with that later. Yeah. That's silly. Assess the problem. In our institute, you come every 2 weeks, and we're looking at x-rays, and I'm looking at you. I'm looking at your leg in front of me, and I'm looking at your x-rays. How are you doing? How are your nerves doing? Do you see something wrong? Let's talk about it, and let's identify a problem. But you have to be able to have, the next order of thinking is, wait, this isn't going according to plan. What are we going to do about it? Some of these surgeries aren't that technically challenging. I could train someone to drill here, screw here, and it's like an assembly line. If everything's going great, there's no problem. But it's recognizing when there's a problem and saying, hold on, stop. Yeah. We're not just doing the next step because that's what the book says. We're doing it because it makes sense. So if you're developing a deformity, hold on, fix it, stop, adjust. That's why they're coming to you.
Yeah.
Right?
Yeah.
So anyway, I go off on these tangents. I'm sorry.
No, I love that. And I actually want to add another point here is, I mean, maybe we were thinking about circular ring, hexapod or ring fixator, but I'm thinking lengthening over nail with a monolateral, like a monorail.
Good question. Okay. So I have converted a monolateral into a hexapod. It takes some finagling. And so you attach a ring or a 2/3 ring to the pin block with the 3 pins probably, and then on the bottom one, then you slide the rail out. It's a lot of tinkering, but especially a monolateral fixator. So a monolateral fixator, it's pretty much all dependent on your first pin. If your first pin is off by 4 degrees, then you're going to lengthen, or if the fixator bends, or if there's a rotational torque. But the nail helps, but you can develop deformities with fixators. Different fixators, different brands have abilities to do some angular corrections, and there's some finesse things you can do. But you're right. I always, in my mind, when I think of fixator, I think hexapod, but you're right. Probably a lot of the lengthening over down the tibia is with the monolateral. You could do it though. You could certainly, you could turn it into a hexapod. You could do it. Just because the problem's happening doesn't mean they have to live with it. Fix it.
Yeah.
Fix the problem.
Yeah. And there's clinics that are popular now that I see this LON or especially on the femur, and then the patients do extreme amounts of length and they end up with some sort of valgus knock-knee deformity because they don't know what they're doing. The surgeons are just not experienced enough to see those issues come up, so. All right. All right. So we're moving on here. So that's his question. He says, thank you very much. All right. So the next question, as we expected, any updates on the Precice Max?
So no update that I have. I don't know if Dr. Paley's done an update. So as June 1st gets closer, we'll hope they have their production up and running. We have patients scheduled in the beginning of June, and we have not heard any reason to cancel or stop that. I wish I could tell you, I can't think off the top of my head. I think we put in 20 max nails before they were not available again. Not one single problem in one single patient. All of them have the ability. Actually, one patient outweighs the rods he has. And so he can stand because he doesn't outweigh it with equal weight on both legs. So he's using either crutches or a walker for all of his walking. But the other patients who are under the weight limit of the nail that we determine is safe, 150 for a 10 or 200 for the 11.5, they're all walking, which is great. Now, none of them are coming in unassisted. They're using either at least a single cane or a crutch. They're walking short distances unassisted, but for safety reasons, even with the weight-bearing nail, you're using something to go up and down a curb. There's an incline, you trip and fall. You don't have the reaction time or flexibility or strength to catch yourself. So for out of the house where you don't have walls and furniture to hold on to, we are asking that they use some sort of assistive device. And maybe, our longest length on a max nail is probably about almost 2 inches now. I saw them, I think, at 42 a week ago. So they're about 2 inches of length, our first max nail. So kind of cool. So we did not get defective nails. All the nails that we put in, we tested before we put them in. We test them when they're in. And we see all the max nails I've been seeing every week for the first few weeks, just because somebody had a problem. We don't want to miss anything. Have not had a single problem with a max nail.
Very cool.
Yeah, I see that about the bent nail. So I don't have a problem with the nails bending, and there's probably examples you can show. The tallest building made of steel and concrete will bend in the wind. So it's not brittle and it doesn't fracture. A flagpole in the wind will bend and sway. An interesting thing, and if you remind me, I'll send you pictures and you can post it. I think so the bending happens if it's a narrow nail that's very long and a patient with a big distraction. So 10 millimeter, 8.5 millimeter nail with 8 centimeters of length, and the bone is lengthening, and then there may be a 5, 6, 7 degree, very subtle bow. That doesn't bother me. The nail isn't, if I pull that nail out, when it comes out, it's straight. There's flexibility built into the nail. It's not a problem to see that. What happens is this is a tie into a conversation we had about a previous patient in the previous discussion, where if the hips get tight in abduction, which they almost all do, right? The tensors get tight, so they get flexion and abduction. But you don't want to walk with your legs out like this. So you purposely bring your feet in, you bring your feet underneath your body. So what you're doing is you're creating a torque to bring your feet under your body, and that torque can go through the nail. So if you remind me, I'll send you. So I have a picture of great x-rays of a patient standing on their last day. They're ready to go home at 7 centimeters or whatever it is. There's a little subtle bend in the nail. And then on their follow-up, when they're healing a month or two later, boop, the nails are straight again because their muscles are relaxing. So people come in, and I'm guessing there's, is my nail bent? Maybe. It doesn't bother me. Nail bending does not equate to nail breaking. So let's be very clear.
Gotcha.
So lots of P2 patients have had issues with broken crowns. I take umbrage with that. It's not lots. Now, in our practice, we were very strict with our weight-bearing precautions. We don't let you walk too early. That's through lengthening and consolidation. The number of broken crowns in our thousands of nails, I can think of 3 off the top of my head. I'm sure there's more. It is not lots. It is incredibly few. If someone is walking and breaks something on their nail and they're exceeding their weight-bearing limit, that is not a failure of the nail. That is a failure of the person who has the nail. If my car crashes because I go 100 miles an hour on a wet road, is the car's problem? No.
Okay. Yeah.
So anyway, I get excited about this.
No.
Because of what you say, because it may not be, yes, it may be true there's broken crowns, but if you're running on your legs, something's going to break. That's why there's a weight-bearing restriction. So
if you're running on your legs, I love it. All right, so we are going to go ahead and so that's the submitted question. So now we're going to live.
So PMax does have a beefed up crown. It has some other design things too, but the basic mechanism of the Max nail is sound. It's the same one that we've had in the Precice for a decade, thousands and thousands of nails placed.
Okay, so they did beef it up.
So no smoking bullet or like June 1st, 100%. I'm going to be in May 8th through 11th, something like that. I'm going to be in Washington, D.C. at a pediatric orthopedic meeting, and I'm actually going to be with the Globus Nuvasive people teaching about Precice to surgeons. If I don't hear anything by then, I will be sure to. And Victor, you'll know before me. I have no doubt. I'm the last to know everything.
Right.
So no new update, but we the Paley Institute, we are assuming that June 1st or first week in June, but I don't know what day of the week June 1st is, that we're going with our Max nails.
Cool deal.
So,
all righty. Yeah. All right, guys. So what we're gonna do now, we're gonna go into the chat. Dr. Robbins, you still good on time for a little bit?
Yeah, I'm totally good. Marshall is chomping on his bone.
I love it. All right, so here we go. We're gonna go into the live Q&A. So I'm gonna bring these up on the screen. So we have Branko's asking. It says on your on the website, that the conservative lengthening limit is 5 centimeters. From where does that
Yeah.
number derive?
Sure.
Is it based on certain percentage of the starting limb length? If so, what's the percentage?
No. So Dr. Paley, who's been lengthening limbs for 38 years now, maybe 40,000 limbs reconstructed, has studied a lot the complication rate relative to lengthening, and in general sense, in an adult during lengthening, once you go beyond 5 centimeters, the chance of complications increases. However you define a complication, a contracture, a nerve irritation, delayed healing, stiffness, dislocation, whatever it may be. So it comes from that data. Now, personally, it just intuitively makes sense. If someone can lengthen 5 centimeters or 8 centimeters, most people, just their tissue compliance can handle the first 1 or 2 centimeters pretty well. At some point in time, it's not just stretching, it's actually the tissues have to grow and they have to actually lengthen, not just stretch, to add more cells and more tissue. That's why the metabolic demand is so high. You're not just stretching your muscles, you're actually growing muscle, you're actually growing bone, growing arterial and vascular supply, growing skin, all that stuff. So as you add more length, you're taxing what your body can do. So that's where that comes from.
Gotcha.
And then, yeah, so.
Yeah.
Not,
yeah.
it's
He was
not a
asking about
percentage.
percentage. Yeah. So.
Yeah.
All right. Okay. So the next one here from Alex is saying, "Hey Vic and Dr. Robbins. So Tuesday I got a surgery. This Tuesday I have surgery coming up because my rod has not been lengthening."
Okay. So.
I think
So the first question, so
Yeah.
if someone comes to clinic and they're rod, and we're assuming it's a Precice, right? Assuming it's a Precice. Before you go to surgery, make sure it's the nail. So how do you make sure it's the nail? Well, there's 2 parts in this. There's the rod and there's the machine. So first, test it on another machine, right? Maybe your machine is broken. It seems like it's working, but we have machines in our clinic, and if someone's having a problem, are they putting the rod in the right place? So our kind of protocol, if we don't think something's lengthening, so you take an x-ray and one side is lengthened 11, or one side is lengthened 10 millimeters and one side is lengthened 6. Well, it's lengthened, but it's not lengthening equally. That's a concern for me. So first thing I do is just, we get our compass and we roll it over your leg. And did we mark the magnet in the right place? I'll have you bring your machine and try a lengthening in my presence. What does one side sound like to the other? Or if just it's unilateral, does it have the normal sound? Is it making a grinding or shimming or anything like that? So is it marked properly? Are you pushing hard enough? Is it set in the correct direction? Maybe it's in reverse, or you're switching the machine and you're compressing and it's back down to 0. It can't go anymore. So maybe you're not lengthening. We don't know if this is their first follow-up or 6 centimeters in. Maybe the bone healed. Maybe the osteotomy wasn't as complete as you thought it was. Did you test the nail before you left the operating room? So the answer is yes to all of these. We test the nail before it goes in. We test the nail after it's in. Which means we've confirmed the osteotomy is complete, but we do that radiographically before the nail goes in. So so before you jump to surgery, test the machine. Maybe it's true. And then how are you going to, what's your protocol to test the nail in surgery? So let's say we proven it's not the machine. One side's lengthening and one side's not, and there's a lot of bone. Okay, I'm pretty sure. And you didn't go running, jumping, or anything like that. So I'm pretty sure the nail is broken. I may not know why, and this is a very rare occurrence, but let's say there's obvious consolidation. I got to re-break the bone. Well, sometimes what we can do is, one, to get the right eye, you have to take the screws out. If I take screws out of the bottom, is the bone going to collapse? Well, if it's so healed it's not lengthening, then it can still collapse, because lengthening takes a lot more force. Even if it collapses just a half a centimeter, you're losing that length. So your surgeon may actually attach a temporary fixator to hold the length, so you can do what you need to do. And if you need to switch the rod, you don't lose the length. So a way you can do this is you can put the fixator on, you can take the screws out. While the nail is in the person, you have the fixator holding length, you put the machine on, and you look under x-ray. Is the nail lengthening without the screws? And if it is, then you can compress it back, put the screws in, and you've proved the nail works. Now, try it again. Maybe it'll work, but maybe now you have to break the bone again. So there's lots of things to do. So just because you're going to surgery, make sure you leave knowing your nail works. And how do you know the nail works? You test it and you document it.
Yeah,
So
that's a really good
so
way.
that's unfortunate. It happens, but good for your surgeon for recognizing this and coming up with a solution. It's unfortunate that it happened, but even in the best of hands, with the best of intentions, things can happen. And that's why safety is always number one. And that's why you have follow-up, and good for you guys for recognizing the problem.
Absolutely. And for Dr. Robbins giving you a checklist to check.
Yeah, can't keep all my tricks.
Oh, I know, right?
Yeah.
All right. Branko's back with another one. He's saying,
Okay.
if 5 centimeters is conservative in the femur, what is the conservative amount in the tibia?
Probably 4. I mean, conservative is it is a little bit of a loaded term. I think about it in the chance of, if everybody wanted 4 centimeters, would everybody get 4 centimeters in the tibia? Now, obviously not everybody would, but everybody would get 4 more than everybody would get 5. Certainly more than everybody gets 6 or 7 or 8. So, and that's for the tibia. So 4 to 5 is pretty realistic, but it's not easy. Even 3, you can have problems. And in the femur, if everybody wanted 5, almost everybody would get 5, more than everybody would get 6, 7, or 8. So patients will say to me, what would you do? In my perfect world, a 5 centimeter femur lengthening, for many, many, many reasons, you recover faster, you heal faster, you get less tight. 2 inches is a huge amount. But we're not doing it for me. We're doing it for you.
For me, it's 6. I want to get to 5 foot.
Yeah.
All right. Branko has another good question here. He's saying, is axial deviation in the femur inevitable? Is there a certain limit of lengthening that can prevent this?
Yeah. So we've talked about this before. So if you're looking at an X-ray, the femurs aim towards the knee a little bit like this, the way we measure, because the ball of the femur is here, and then the pelvis is here, and then the shaft is here. So by virtue of the rod going in the femur, it goes in the hollow part of the bone, the anatomic shape of the bone, called the anatomic axis. But fixators, if they're perpendicular to the leg, they lengthen along the mechanical axis. So yes, and Dr. Paley wrote an article on this in the 90s in the Orthopedic Journal, that basically for every 1 centimeter of length you get along the anatomic axis, in theory, you bring the knee in just a little bit, and that can create valgus. But if your rod flexes just a few degrees, that happens to sometimes cancel out that slight valgus deflection. And that's why rod bending doesn't really fuss me at all. So the amount of axial deviation in a mathematical world is about 1 degree per centimeter, but in practice, it's not often that. The nail has a little bit of toggle, so the bone may have a little bit of shifting, whatever the reasons are. Another way of asking that is, how many patients who have lengthening of their femurs develop valgus to the point where they're having corrective osteotomies? I'm sure it's happened. It's a very low number. But you're right. It's a great question, especially let's say you're in a place where they're doing 10 centimeters. Well, the chance of it developing a 10 is much more than 5 or 4. But guess what? As we say to all of our patients in the preoperative visit, your grand plans before you undergo surgery are X, Y, Z. Your plans are allowed to change. I'm giving you permission to change. You may not want to hear me. You may think I'm crazy. You're going for 8, come heck or high water. You're allowed to change your mind. If you see my femurs are looking wrong, or my appearance isn't what I thought it would be, or I love my appearance now at 5.5 centimeters, then don't go more. What are you doing? I'm starting to get this whatever it may be, axial deviation. Okay, are we going to keep going and maybe it gets worse? Are we going to fix it now? Do we fix it later? If it doesn't bother you, so lengthening happens a day at a time. You should never walk into the doctor a month later and be shocked by something. Like, oh my gosh, I never noticed my leg is 1 inch longer than it was a month ago. Well, you should have noticed because you've been lengthening it every day. It is shocking what some people say. I never looked. I just realized my tibias are longer than they were, than I wanted them to be. What are you looking for? You should be looking. So, and I get it, because in the first several weeks after surgery, it's where do I put the machine? How often do I do it? Where are my medications? Did I take my vitamin D today? When's my appointment? Oh, the bus is coming for PT. You're just trying to stay above water. I want a glass of water, but I don't have my walker. My mom said it, you know? So in the first several weeks, you're just like overwhelmed. But after a couple of weeks, I don't try to overload my patients in the beginning, but then I'll say, hey, this is a silly thing to say, but I want you to actually look in the mirror and look down at your legs, because I want you to see the change that you're creating. I don't want you to forget why you're here. You're not here just to say hi to me every 2 weeks. Hi, Marshall's call. You want more? Okay.
Oh, he's done.
Yeah,
Go ahead.
Yeah,
this will be a long one. We're in for the long haul.
No, we're okay. I'm just gonna.
Okay.
So yeah, so look at your legs during the process. You're going to be shocked, and that idea, I have to have 8 centimeters, it goes away once you start actively doing something for this, and you're intervening in this thing that's affected you for so long. Like the switch flips, and whether it's 5 or 6 or 8, it kind of fades away. It's kind of cool to see. I love it. I think it's fascinating seeing the psychological transformations throughout the process.
Now, Dr. Robbins, do you depend on the rod bending to counteract this activation?
No.
Does it happen? Is it dependent on their structure?
It's their tightness. It's the size of the bone. It's the size of the rod. It's the length of the distraction gap. It's the amount of healing. There's so many things. So I right. How many patients need a surgical correction for an axial deformity to a femur lengthening? I'm sure it's happened, but I can't think of one.
Okay.
I'm sure it's happened, but I can't think of one. But understand that in theory, if you lengthen internally along the femurs, valgus is a potential problem, and that's predictable because it lengthens along the anatomic axis.
Gotcha. That comes with experience.
So great question. Great question.
That was good, Branko. I got to give it to you. Alex is saying, should he be mad at himself or the manufacturer of the nail?
Which one's Alex? That the nail's not working?
Yeah, the nail's not lengthening.
Well, if your bone healed too fast, you could be mad at yourself, and it's not going to help anything. If the nail has already been lengthening and suddenly stopped, again, I'm sure that's happened. But our rate of discovery of a nail not functioning in the operating room is, again, these are such rare things. Maybe it's happened once. I don't know. Our rate of nails stopping working without known trauma or over stressing it, again, I'm sure it's happened, but it is so darn low. It is so darn low. So Alex, you don't have to share all your personal details, but hopefully after surgery, maybe you could tell us what happened. Maybe there's a critical analysis to figure out what problem, and maybe you have some insight for me, please, or for other people going through this, things to look out for, maybe something I haven't even thought of. So please, if you're willing to share after you know the solution, please share it.
That would be great. All right. Ranko's back with another great question. He says, does lengthening the tibia increase the risk of Achilles rupture long-term since there's no lengthening of the Achilles tendon?
It shouldn't. I don't know of any of our patients who have had a rupture after, but we have our patients going back to normal sports. You can rupture your Achilles playing pickleball without having surgery. Paley Institute, we don't do soft tissue like Achilles lengthening ever, not for stature. Achilles lengthening leads to permanent weakness. So I won't let you lengthen until you get tight to the point you need a contracture, which means I won't let you lengthen until it's unsafe, which means the amount of length you have is not consequential to me. Your safety is in your eventual recovery. I will never guarantee length. I will try to guarantee safety. So, and these things don't happen overnight. You don't get tight between day 15 and day 16. You get tight slowly over time. And that's why our therapists see you every day. That's why you do it here with us. They're your front line. And that's why I see you every 2 weeks and examine you myself. So lots of off-topic things to what you're saying, but no, I don't know of anyone who's had an Achilles rupture after lengthening, because we're not lengthening it. We're not surgically lengthening it.
Right. Now, let's say that a patient did this at another clinic. I call them inexperienced clinics, where there's patient pleasers. They let the patient lengthen 8 centimeters on the tibia where they have a severe equinus contracture. They somehow get their heel back down to, I guess, let's say 10 degrees above, neutral. And they go for running, jogging stuff. Are they predisposed to getting an Achilles rupture?
That's a good question. I don't know. I've never heard of it or read it. Maybe there is, but
there's a lot of them.
There's a lot of them. Are there really? They're all?
Yeah. It's alarming. They come through my email. They're online. Yeah, they are.
Wow. I mean, it makes sense mechanically, because you're shock loading.
Yeah.
So the difference between landing on your heel and your heel pad, your heel pad is compressing to take the load. That's why your heel pad is so thick. But if you're landing on the front of your foot and then you're shock loading, that's an eccentric stretch, and that can overwhelm the tendon. So it makes sense you say it. We've never seen it because we don't let it happen.
Absolutely.
We see quite a few patients who have mishaps, misfortunes, bad luck, whatever, from around the world. I've had patients come to me who have had 6-7 centimeter tibia elsewhere, and then they come to us for femurs for reasons. And more than a few of them have completely stretched it out. I'm like, wait, you did 7 centimeters? Oh yeah, I walked on my tiptoes for months and months, and I had no formal therapy. And they come in and they have active dorsiflexion. I'm like, well, first of all, good for you. But man, how amazing and resilient is the human body? Holy cow. Right. So yeah, so you, Victor, your whole purpose for these stature things is know what you're getting yourself into. Don't develop the contracture. If you're getting a contracture, speak up. I'm getting a contracture. Should we stop? Should we slow down? Should I go somewhere else? Should I get physical therapy? Holy cow.
I know.
Because your doctor said it's true. Nobody cares about you more than you. Maybe your mom and dad or your siblings or your spouse. But I encourage, be your own advocate. You're on here to get information and ask questions. If you're getting tight, again, maybe that 6 centimeter tibia goal is a little too much, I think. Not likely. But maybe you got to temper it a little bit. I'd rather you get 4 and be healthy and whole than get 5 and be on your tiptoes, because you get an Achilles tendon rupture apparently.
Yeah, absolutely. And I think that's the big dilemma that we have with this procedure, stature lengthening. It's like, I call it the stigma, because there's a lot of clinics that I call patient pleasers. They just want to make the patient happy. Pay us your money, we'll take your money, and we'll get you your goal of 6 centimeters or whatever on the tibia. Whereas, like you said, yourself, you focus on safety, and you're not a patient pleaser. You don't care. Don't get me wrong. You're going to get them as close to their goal as possible. But should they run into a risk of developing a severe contracture, and like, hey, we're stopping lengthening, I don't care, and you put your foot down. I like that.
But again, it's very, you're not going to show up and I'm going to say, hey, we're stopping today.
Right.
So it's the therapists are going to tattle, which they're supposed to. They're going to tell me on Monday, boy, they're really tight. And I'm going to email you, or Angelique or Liam is going to say, what the heck? You haven't been going to therapy. Are you wearing your splints? Marshall. You're not stretching enough. We may slow you down. We may stop you. And below the knee, it's really a challenge, because if the tibia is healing okay and the fibula is really healing and I slow you down, your fibula may heal. If your fibula heals, that may pull you into valgus. That may preclude further lengthening. But you know what? You're the one who got tight. It's nobody's fault. Maybe it's nobody's fault. Alex, should we blame you, or should we blame my therapist, or blame me? If you're getting tight, recognize it early so you can treat it aggressively. More splinting, more home stretching, better stretching, different stretching. Have someone come help you stretch, whatever. Recognize these things, because they tend to happen in slow motion, and you jump on it early so it doesn't get worse down the line and then lead to ruptures, etc.
Absolutely. Well said. This next one, Fate, he was a patient who got lengthening on his femurs before, but he's coming back, and he said that he got a second surgery on April 15th, but he went to the bike. He started doing the recumbent bike too early, and he has a big bruise and pain when he tries to flex his glutes. Do you have any advice on how to fix it? So is it a muscle strain, or?
I mean, most likely, I don't think he ruptured the glutes. Was it trochanteric entry? Was it piriformis entry? How tight are they? Did it, So here you are, poor Fate limb has this problem. Hopefully you have access to a good physio. My wife is a physical therapist, and she is so astute at diagnosis. Her evals, like, you come in with an ACL. It's not like, oh, you had an ACL reconstruction, let's start therapy. It's like, I'm going to check your feet. I'm going to check your hips. I'm going to check your back. Total thorough eval to know how this affects you. So you need a good physio. Rest, ice, anti-inflammatories, cold plunge, massage, all those sorts of things. That's a bit of a generic question for me to answer. So I apologize. I don't have anything much to help you.
Unless you saw him in person. Yeah. Okay.
Yeah.
Okay. Brink was back with another good one. I mean, this guy's just killing it today. He's going to get the MVP award, but he's saying.
So in our practice, we use general anesthesia 99.99%. The reality is, if you have this discussion with the anesthesiologist, what's safest and best for you, as long as you don't move and you are anesthetized, when I'm doing your surgery, it doesn't matter to me how you get there. And that's a conversation for you and our anesthetist. And I don't want to say anything wrong or contrary. They may have very good reasons why we use general anesthesia a heck of a lot more than we use sedation or regional or something like that. We don't. We have very good results doing it the way that we do, and we see no reason to do it any way differently. But I have done surgery under regional or spinal or something like that for whatever reasons. I don't mind as long as you, the patient, are adequately anesthetized and are not moving and having pain or problems.
Gotcha. Okay. Branko, you could. This is open to everybody. So you ask your questions. You get Dr. Robbins, take advantage of it. So he's a young adult in excellent shape, and he had moderate, severe Meralgia Paresthetica.
Yeah. So that's an interesting thing. So any existing problems you have the potential to be exacerbated by lengthening. So what can you do to try to get them away? So it's interesting. Most people, so if you don't know what Meralgia Paresthetica is, you can look it up. But there's a nerve that runs on the front of the groin, and it's typically described in patients who have a little too much on their belly, or they wear tight pants, or they wear a belt, and it's literally your belly pannus, the fat of your tummy, pushing over this nerve, and it puts pressure. And it's like carpal tunnel in your wrist from being on the keyboard. It's like carpal tunnel in your hip, in your thigh, and it makes this burning and annoying pain. So we've had patients develop nerve stretching things. That one's rare to get during lengthening, but I have had it. And I've had patients with other orthopedic problems where I've actually done a release. It's like a carpal tunnel release. You do it's called a nerve decompression. You make an incision in the groin and you take pressure off. But the hip impingement worries me actually the most. Why do you have the hip impingement? Is it a rotational thing? Most patients who have, I shouldn't say most, there's a subset of patients who have hip impingement, and some of it is due to the shape of their femur. Nobody's fault. It's just the shape of your femur. You're not doing anything wrong. And if that's recognized and understood as part of lengthening, if we're going to cut the bone to add length, we can also cut the bone to change the rotation, and maybe that offloads your impingement. And we've done that more than a handful of times. Either walk too inward or you walk too outward. But yeah, my he'll probably respond. I'm curious if he has retroversion where he's walking external. So he has to force his legs in to walk with his feet forward. That can be addressed during lengthening, do the osteotomy, or just address it without doing the osteotomy. So the take home from this question is, if you have a pre-existing or a previous problem, back pain, sciatica, whatever, absolutely it can be made worse by lengthening because you are stretching things, and equal and opposite reaction. If the femur bone pushes this way, the muscles are tight pushing back, and that puts all that pressure up on your hip. So yes, your nerve and impingement problems can be exacerbated. Now, how are we going to know? Well, we lengthen a day at a time, and we adjust to how you are actually feeling. Maybe you're going to have to go slower. Maybe you're going to have to do more therapy. Maybe you're only going to get 4 or 5 centimeters, not 7 or 8. But I'm not arbitrarily going to make that decision today. We're going to assess you individually, and every time I see you, we're going to have the conversation. How are you doing? Do we think you can recover from whatever these problems are and get back whole when you're done?
That's well said. Yeah, absolutely.
I hope I'm answering your questions, Branko.
Yeah, Branko, and let us know if is it retroversion or is it anteversion, you said?
Yeah, usually retroversion.
Okay.
Yeah.
Okay. Darko's asking, hey, Victor, I'm currently treating a patient post-lengthening surgery. What's your thoughts on using peptides for recovery? So
that's a great question. I
get it a lot.
so I'm not naming names. One of my wife's friends, now I shouldn't say this, you get on social media. Anyway, I know a guy who swears by peptides. So this guy, he's Serbian. He's so awesome. Anyway, he came into my house about 2 years ago. He's like a CrossFit dude. And I think when he ruptured his Achilles, it was like walking down the street. Like, it wasn't squatting 600 pounds. It was like something so silly. So he comes in, he's like, dude, I think I ruptured my Achilles. And he's got an Achilles. With my own eyeballs, I measured his gap was a full 2 centimeters. Like, there is nothing there. And I'm like, what are you going to do? I called my sports buddy, and we lined up surgery, and he was going to go home. Anyway, so he's like, I'm not having surgery. I'm Serbian. I'm going to treat this myself. So he put himself in a boot in Aquinas. I'm not kidding. He was back running in 4 months. He has no gap. He has no weakness. He's a huge believer in peptides. He's a huge believer in peptides. I don't know if they're IV or injection. So I've heard of these peptides. I know what a peptide is. We have no personal experience. And we look at it from the other way. Our patients generally recover and do well, and they're not taking it. So what's the benefit? So that's an anecdotal story of a guy with an Achilles rupture that healed, and he says, hey, I take peptides all the time. Maybe that's the magic bullet. It's not part of our practice. Now, if you said to me, I want to go get peptides, I have no reason or no knowledge that you shouldn't, but I don't know how the peptides are given. Is it through the vein? Is it an injection? Is it a pill? I don't know. It's something I don't have enough information to make comment on. But the things I've heard of peptides are amazing for recovery, whatever that means. Do they increase your risk of blood clot? Do they increase your risk of cholesterol? Do they increase your risk of other things? I don't know. So I don't think this is a regulated thing. I don't know if you go to Dr. So-and-so and say, hey, Dr. Mary, I'm getting my testosterone replacement. Do you also do peptides? I don't know how that works. So unfortunately, I've said a lot, but not much. I don't have much to say except anecdotally, I've heard wonderful things about them. But
I can't believe that. That's
but our patients, I think, are doing pretty great, and they're not using them. So
yeah, and I agree with you. I think that when most patients, they don't need it, diet, just lengthen and observe. But this is interesting because a lot of patients have been asking me. So with my biomedical background, I might do a video on this just to kind of like explore it now that you
should.
Talk
and then here's my question for you. And I'm taking this question, and I feel like Victor, we've been doing this a long time together.
Yes.
And I think we now kind of can feed off of each other, our questions and our answers, and you know how to get me going by asking the right questions.
Great.
But I've also learned, and I said this, I think last time, like, I hear the question you're asking, but I say what I'm going to say because you're asking me and I feel like talking. So let's spin it a little bit and say this way. Let's say peptides cost $1,000 a week. Let's say getting peptide injections is 3 hours out of your week to go get whatever. I'm just making up numbers and that means nothing. If you come to me and your Achilles tendons are getting tight, does that $1,000 in 3 hours out of your week mean more than stretching 10 hours more or having 5 more hours of physical therapy or paying someone to come stretch you? No. So I can never say one of my patients has their problems because they didn't get their peptide injection. But I can say plenty of patients had problems because they didn't. Boom, 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 boom.
Right.
So I love that you are asking about peptides and all that. But what's going to get you through lengthening is not the newest, latest science, because peptides didn't exist when Alizaroff was doing this, and he had pretty darn fantastic results. What gets you through this is moving and stretching and nutrition and hydration and doing all the right things. So just because there's a fancy pill out there isn't the cure to all of our woes. So it's a great question. Maybe it's an adjunct. If I take steroids, Victor, I'm not going to look like you unless I take steroids and I do 40 hours a week in the gym, right?
Right, exactly.
So peptides make me feel better, but there's a lot of things that make me feel better that I don't have to pay for and inject.
I agree.
Anyway,
I agree.
So that's my little side thing is, there may be new and great things, but the old-fashioned things you still got to do. You can't take away the time and the grit and the hard work to get through lengthening. There is no simple way to get through lengthening. Get on the floor and stretch. Get on your slant board. Get mom to get you in the Thomas stretch. Whatever you got to do. There's no easy way to get through lengthening.
But I think everybody just wants that magic bullet. Like they're like,
it doesn't exist.
Everybody wants convenience. They want that Thanos snap to get back to normal.
With stature lengthening, there is nothing convenient.
Yeah, exactly.
It is hard to be prepared.
Agree. J-Red's basically saying that they talked to 5 Paley patients, and then they said that all of those 5 patients had proximal IT band releases. Is it really 5% of patients get? I'm
sure I can think of 5 patients in the last 6 months that have had it, but not all in the last 6 months. It is really low. But it's if 10 patients come in a row that are very tight, then all 10 are going to get it. Yeah. It's not. So I appreciate your question. And a statistic is, what's the saying? A statistic. There's liars, damn liars, and statisticians. So yeah, if 1,000 people come in who are Olympic gymnasts, probably 0 of them will need a release because they're very flexible. But in general, it is a very low percentage of patients who get the proximal release, either at the end when we take the rod out or on the front end. Yes, to my mind, in the last couple of months, we've had a few patients who were tighter than general. And so we have done some proximal releases. But Is it also because people now are waiting for the max nail? And just like with stride, once the rod becomes full weight bearing, the patient population coming for the nail is different than the non-weight bearing, because the weight bearing population who are like, ooh, there's this new thing, and there's less buy-in. If you knew you had to be on crutches for 6 months with a 50-pound limit for the femur, that deters a lot of people, right? Whether it was Precice 2 or whatever, but still people came. But those people in general, I'm generalizing here, had probably been thinking about it longer, are probably more prepared. So maybe they've been stretching and doing the things to maximize their things. So it could be a bias of the population. I hear you, Marshall. That now that the weight bearing nail opens up a whole new group of patients who are coming to have this. Maybe they're just not as flexible, or whatever. But yeah, it is still pretty. I cook for them, so they get a half kibble and half my, maybe 2/3 kibble, because the vet said they have good kibble. It gives them balanced nutrition. But they like what I make for them. They get like once a month I make like 30 pounds of ground beef, spinach, carrots, sweet potatoes, rice, peas, green beans, and I have this huge thing. It takes me all day, and I freeze it, so they love to eat.
That's incredible. You're going to put a blue buffalo or whatever out of business. Like, that's incredible. Look at the Robbins dog food.
Exactly. The kids and the dogs. Yeah. So whatever the number is, it's not like I flip a coin, 20 people come in the door and one gets it. It is dependent. If 10 people come in that are very tight, then the number for that month is going to be higher. We're doing generalizations over lots and lots of agents. The point isn't how many people get it. The point is that we are assessing you to see if you need it, and we're discussing that you may develop the contracture. So I appreciate your question, Jay, and the fact that you're thinking about it is great, because it means that if you're having surgery, you're going to spend a lot of time stretching so you don't get the contracture there, or at least recovering when and if you do. So great question.
That's a good question. Very good. And I think even when we were doing the documentary, I think Rich Rotella had to get it approximately, because he's a more muscular guy, so he's going to be a little bit tighter.
I don't remember. And I wouldn't say, but I don't remember.
Yeah, I know. I think he did. I have a pretty good memory. So, all right. This next one from Richard. He's saying, "Hello, I'm 55 years old and I'm 5'5", 240 pounds. Money is definitely a factor, and I'm getting the surgery, so I have to go to Turkey. With my age and weight, can I assume I will get at least 3 centimeters,
Nope.
3 inches in my femur?"
If you were 24 years old and weighed 120 pounds, you can't assume you're going to get 3 inches. 3 inches is a lot. 7.5 centimeters is a lot. It is a slog. 240 pounds, you're going to Turkey. I don't know the way they do it in Turkey, whether that's lengthening over nails. That's a lot of weight to put on a Precice, if it's a Precice, because a Max is not in Europe. Okay. Just be very prepared. Rich, hopefully, is going to get to do an interview with one of my patients who had lengthening with me for the femurs, and then for reasons he can discuss if he chooses to, went to Turkey and actually called me from his hospital bed in Turkey with a complication, and ended up coming back to me, and I treated him, took care of it, and everything's fine. But he has a lot of insight. And hopefully Rich will get together with him, whether it's one-on-one like this or it's just anonymous, just information, not maligning any other institutes, but just comparing and contrasting the two institutes he had experiences with. So good luck, Richard. Just be very careful, ask a lot of questions, be an advocate for yourself. Keep us posted, let us know.
Yeah, absolutely. And I like you just said, I plan to do interviews with patients. I'd like to set up a complications roundtable where I talk to patients from clinics. I call them inexperienced clinics, where they've gone and they've gotten these developed complications.
Fair, because we can have complications too. So that's not quite fair, because we have a lot of experience. We can have complications too.
Yes,
so,
but
I have to give a little bit of a wall.
The thing you're not, the thing you guys aren't, and other top clinics, you guys aren't patient pleasers. Like you will try to please the patient, but at the same time you keep safety first and foremost. And other clinics that I see,
even in that situation, we can still have complications. So I take a little umbrage to you saying inexperienced.
You're very modest.
You may be right. They may be inexperienced. That's for time and statistics to decide. But whatever, I appreciate you're going to have you're going to have
I will
discussions
have
with patients.
several patients on for that, and I'll share the link with you after I'm done. You're like,
Yeah.
oh, okay, Victor was right.
Yeah. Right. Well, so I really hate to say this, but like that thing, what you were just telling me about the Achilles ruptures, you're running in Aquinas and that being common. I just learned something. I hate when mistakes happen, like an accident. I hate when complications happen, but a complication doesn't mean a bad surgery or a bad surgeon. Just sometimes it's a numbers game or things out of control. But part of the reason why I think I have some modicum of success is that if there's a complication or a problem, I learn from it, and I really try hard not to make the same mistakes. Like Dror has said this probably on your thing, and 100 times, you could Google it. He said, I don't make many problems or complications now because I've already made them all. We developed the field. He's the first to say, learn from my mistakes. Don't do that, silly. I've already done it 50 times and it didn't work. Do it this way. Maybe he says it a little differently than that, but it's true. We really try to take stock and learn. If something bad is happening, you step back and go, wait, why is that happening? What can I do to prevent it again? Kind of do a root cause analysis. Why did this happen? What can we do to prevent it? Still bad things happen, but I would love to watch it because, wow, I didn't know that could happen. Maybe I got lucky. There's a saying in medicine, especially with inexperienced, you're early in your career and you haven't quite seen everything yet, is I've never seen that problem, but I'm sure it's seen me. I just didn't recognize it. So yeah, complications can happen. So it doesn't mean they're inexperienced. So I take a little umbrage to that term.
Okay.
Anyway, carry on.
All right. Well, maybe they just don't put safety first and foremost, because I care about patients and I want to make sure that the standardization of stature lengthening is the bar is raised, right? And I think that using big leaders in the field like yourself to kind of like highlight and say, hey, look at the track record of success over here with Dr. Craig Robbins, and that's kind of what I'm trying to do. So that's what I'm doing.
I know. Okay.
Okay.
So again, I said it and I'll say it again. I think we have about 20 nails in, except for one patient who weighs more than the amount that we declare safe for him. They're all weight bearing. They're all allowed full weight bearing in the house. They're all doing that. I watch them all walk, so they're all doing it. But they use assistive devices for distances or out of the house or for safety, for sure, out of the house. Hello, Marshall. So let's say 20 nails in. The first patient is coming up on 5 centimeters. We, knock on wood, have not had any problems with the max nails.
Awesome. Very cool. So Socrates, regular here on the show, he's saying, Dr. Robbins, what's the healthiest way to get back to marathon running after distraction, after lengthening?
It's a great question. So first of all, you should probably be a marathon runner before.
Yes.
But then you're getting back. So, this makes me want to email. So we have a guy who's a very experienced. This guy was, I swear he's a sub 3 hour marathon. No, maybe he was a 3:15. Like anything under finishing is amazing. Let's be very clear. So for you, Socrates, this guy was like a 3:15, like a crazy marathon runner. We lengthened him, I want to say about 6 centimeters. We probably got it maybe a year ago. So I wonder if he's back to running those distances. So first of all, go to a place so you potentially don't have any problems or complications. Stretch like the Dickens before, during, and after. But once your bones are healed, which, all things being equal, 6 months from surgery, whether you have max nail or whatever, and you have enough bone healing to start running, you get back to running. Again, I spoke about this with the patient population. With the weight-bearing nail, a different type of patient is coming because it becomes more accessible. It's more of a challenge for me to be on an assisted device for 6 months. But if I can walk and use just one crutch, it opens up to a whole new breed of patient who may not have, the buy-in for lengthening over nail for 10 years. You know what I'm saying? It becomes more accessible to people who never thought about it. So we are starting to get patients who are more athletic than other sorts of patients might have been. So there's no reason you can't. And when you cross the finish line, please bring the banner. And you've probably done the math. If you run at this pace, you've taken this many steps. If you have 3 inches of length, in theory, you're going to take a lot fewer steps. It'd be interesting to know what happens to your time. But also, if you're running at a marathon, if you're running marathons, expect to be, whatever it is, it's 2 years. It's 2 years to get back. All of your colleagues who are running marathons today with you, who are not having stature lengthening, are still running while you're here distracting. They're still running while you're healing. They're still running in that year when you're not able to run yet because you haven't stretched out yet. And then you haven't run in a year. And now you have to catch up to where you were. And then you have to get back. So it is a real impediment to that high level sport. And that's why we say we are not doing this to make you a better athlete. And really, truly beware. It is a long road to recovery. If you're running marathons, plural, you're probably not doing them once every 10 years. You're doing them, which means you're always running. When is the last time you didn't run for 6 or 9 months? Probably never. So now imagine not doing it and then trying to get back. So the expectation is you're back, by 9 to 12 months. You're allowed to do it, whether you choose to or, that's a different story. So it'd be really nice to have follow-up. Let us know. You tell us. But I have no problems with you getting back to marathon running, and I hope you do.
Yeah, absolutely. We're going to keep a close eye on them. So there's a lot of questions in here. I told you this one's going to be loaded. But what we're going to do, we'll keep going. So we'll probably cap it at the 2-hour mark because we'll get that. But let's see. This question. So Alexi, if you check the latest video, there's a great distribution chart about like average height in America. And I think you can find your answer there. But DJ Cyborg is asking, Dr. Robbins, I want your opinion on this, as there seems to be a ton of differing opinions among various surgeons. I got femur stature lengthening in June of 23, about 10 months ago. And the second part of his question is, if I get tibia stature lengthening later this year, would it be safe or possible to get fingernails removal during the tibial surgery?
So first of all, have you adequately recovered? Can you flex your knees enough to be able to get the rods in? Have your nerves had enough time and your tissues had enough time to recover? Because it'd be terrible to do it too early, and that limits how much lengthening you can get through nerves, muscles, whatever it may be. Lengthening your femurs can make your knees tight. Lengthening your tibias can make your knees tight. So if your knees haven't fully recovered, don't do it too early. In generally, our patients want to do the removal all at the same time. So they leave the femur rods in, whatever's in there, they do their tibias, and they come back at one time. God forbid you have a complication taking the femur rod out. I make one up. You fracture. Now you can't lengthen. You came all this way, you paid all this money, and now you can't do it because you had a complication from the part that was the most elective. I mean, the rods have to come out. Lengthening rods have to come out. So all things being equal, I would wait and do all the hardware removal at one time. It's probably fair to say I have removed more Precice nails than anyone on the entire planet. I've taken out hundreds of them because Dr. Paley is not doing them anymore. I'm doing them all. Took 4 out yesterday. Same patient, 2 femurs, 2 tibias. Yeah, we did reactivation, 2 femurs, 2 tibias today, which is 6 bone cuts in a day.
Really?
Yeah. Wow. There are plenty of complications that can happen taking out rods. So I would say do your tibias alone and then do all hardware at a separate time.
I would love to do like a video with you, because since you're like the foremost guy to remove nails in the world, I need a really good video on like device nail removal. And since you did it, I want to talk about the complications that can happen during nail removal. Maybe that'll give away too much of your secrets, but
no, actually, so some are proprietary. So you get better the more you do. So one of my PAs, I don't know if I should say his name. Anyway, he and I typically do most of them together.
Yeah,
it's like, you work with someone for 10 years, you learn how each other think. When we're in the room together, working together, it is ballet. We don't have to talk. I know what he's doing. He knows what I'm doing. We're passing instruments. We have an orthotechnologist who works with us. We have an industry guy in the room helping with the laser pointer. And it is ballet. It is magic. I'm part of it, and I get excited watching it. There are so many ticks and trips, and I'm not going to give those away. Because it took me a long time to develop them. But I'll talk about potential complications.
Well, that's what I like to hear. Is like what can happen. Because I've heard of like fractures upon removal.
Yeah, we had, it's a long time ago. She had a stress fracture, and I think we put her in an immobilizer for like a month, and she fully healed and everything was fine. But yeah, so I learned from that, and the trick I have now, that's never going to happen again.
Okay.
Yeah.
Very cool.
Yeah.
All right. Como's asking, how often do you have to go to physical therapy for a Precice 2.2 on the femur for femur lengthening, and how much should they expect to pay?
So our protocol is 5 days a week for an hour a day with our therapist, but we hope and expect you're doing at least 2 hours a day on your own. And when I say on your own, there are certain things you can do on your own, but you are best stretched with somebody else. So your friend, lover, parent, colleague, someone you hire comes to your hotel, your house, whatever. Having someone help stretch you at least 2 hours a day, you'll have a much better outcome than if you're just trying to rely on the 1 hour a day we do. That's only 5 days. 168 hours a day, 5 hours, 168 hours a week, 5 hours of stretching is not enough. Tissues need to be on stretch to grow. We're not just stretching you, we're encouraging tissue growth. So the more you stretch, the better. Our best outcomes are 2-3 hours a day of stretching after our stretching. And I try to tell my patients, warm up before you get to PT. If it's 20 minutes to warm up, you just lost 20 of your 60 minutes. Come in hot, ready to go. Go home and finish stretching. Take a shower and go do more. So the more you do, the better. There is no easy lunch, and peptides are not going to stretch you.
That's a good one.
I actually don't know what our rates are. Angelique or Lena can tell you, but our package includes therapy for the traditional lengthening amount, and you can also purchase additional therapy in 1 week increments as needed.
Awesome.
Okay.
Kinsu saying, Dr. Robbins, I plan on doing limb lengthening, but my wingspan is shorter than my actual height.
So that's a tough one. So proportions are aesthetic and are visual to you. We don't lengthen to proportion numbers. We lengthen to your aesthetics. We lengthen until you want to be done, or I tell you you're done. So some marriage of those considerations. So you could probably take a picture of yourself, and you can Photoshop and add 8 centimeters or whatever you want to do. But something interesting to note: let's say you're doing femur lengthening. And the average person stands; their fingertips are about mid-thigh. So if you add 6 centimeters, your fingertips don't change 6 centimeters. Your arms don't look 6 centimeters shorter. They only look about 3 centimeters shorter, if anyone notices, because half the difference is above the hip and half is down below, or half is above your fingertips and half below. So the number of humerus lengthenings we do after low extremity lengthening, this guy is going to tell me numbers, and I've done 5, but we've probably done 5 in the last 9 years. Maybe there's a few more. It is so rare to do humerus lengthening with lower extremity lengthening. People don't notice the leg lengthening proportions. They don't notice the arm proportions. But you're absolutely right. If we're making this a numbers game, if you stand a certain height, your legs are 52% of that height, and your tibias are 80% of your femur length, and your wingspan is plus or minus, a couple percent of your length. Yes, any lengthening will change your ratios, because a ratio is a number over a number. In general, 1 centimeter of the femur lowers your ratio from 80 to 79. 10 centimeters femur would lower it to 10 points lower, whatever. But a ratio is on paper. It means nothing. We talked about this. I don't even know if that was this hour or on the other talk we did. Is after a couple of weeks when you're recovering from the surgery, I tell you to open your eyes and look at what you're doing. Look at your legs. Look in the mirror. Look at how your proportions look. Put on clothes. Put on your favorite jeans. They're getting shorter because you're taller. How do you look? Because we're not lengthening to an arbitrary number. We're lengthening for you, what makes you feel good and whole, and appreciate what you like. Your goal may change. You may want 7 centimeters, but you may get to 4 and start to notice, wow, my proportions look differently, and you choose to stop, and that's great, and I support you on that. So stop. You take a breath from your machine and your stretching, and actually look in the mirror, because you're doing something fantastic to your body. Be happy with what you're doing and pay attention to it. So the wingspan doesn't really play in much, but the fact that you're thinking about it is great, because you're going to be paying attention to that. I'm never going to tell you, boy, your arms look short relative to your legs. I'm going to help you get to the safe length that you want, but you're going to have to decide what looks good to you, because your aesthetics is very personal.
That's true.
And that's why I say the number you have before you start doesn't really mean much, because there are 100 things that are going to influence how you see yourself after you start. Most importantly is that number will kind of fade, because your body and your brain is just going to kind of reset and go, oh my God, I'm doing something about it. This height thing has bothered me for so long, and guess what? I'm not doing something about it. Isn't this cool? And it just sort of goes away. It's crazy.
That's true.
It's amazing.
It's like a switch that's flipped up. But I do find that, like, even though it skews numerically with the numbers, like you said, aesthetically, it's not as bad once they have time to, like, fill out their leg mass and they get back to normal life. It's like, it's not really noticeable in public perception,
No, It's not. And it also is the clothes you wear. If you wear super tight fitting clothes, it's probably easier to see, especially if you're really thin and you have knobby knees. You can see where your knees are relative to your ankles. Guys in general have it easier. You could wear longer pants, longer shorts, baggier stuff, a little higher, a little lower. And a trick a lot of, at least my male patients tell me, because girls already know this, they typically wear heels or platforms. A lot of patients will do their femurs and then their shoes, they just have like built in an extra inch or an inch and a quarter left. The other proportions are almost completely normal, even if that matters. So it's just sort of kind of interesting.
That's a little tip there. That's great.
Yeah, cool. I just took 10 patients away from tibial lengthening.
That's right. They're like, oh, do the femurs. So Zanza's saying, I found out that I have EDS. That's it. Yeah, it's like the connective tissues, like really. Then it says, after having leg length discrepancy surgery, so a 2 centimeter gap, 9 months post surgery, and no growth. Please help.
Compress.
Compress.
Yeah, I mean, you spend 9 months on walker. Compress, get it to heal, live to fight another day. And that's, that is the most basic, just brute gut answer. Obviously, I don't know x-rays. I don't know what they look like. Is there infection, the metabolic workup, all those things. You got a 2 centimeter gap that hasn't healed. Eventually, the rod's going to break, or the screws are going to break, or you're going to trip and fall. Walking around on assisted devices for 9 months, that's not what you expected. You should have been back to running by now. Compress down, maybe that stimulates healing, and your limb lengthening journey, the way that it went, is not what you expected, but at least you get back to whole again. So now you want to have a visit and really look at your x-rays and talk about this, but that's we've done that on somebody. We had a guy who came from elsewhere who lengthened like 6 centimeters in his tibias and got Aquinas contractures and no bone growth, and nerves were irritated. So we took the nails out, the screws out, and we compressed them down. And oh my gosh, you compress them down, the contractures go away. We decompressed his nerves, and he spent all this money and went somewhere to save money. Ended up spending more to have the reconstruction, and he got very minimal length from it. So again, Zanza, don't know your particular situation, but there's big surgery to cure gaps. Or maybe there's a simple surgery, simple-ish. Take the screws out, compress it down, and put the screws back in. Swap the nails out. That's horrible. I'm sorry to hear that. I'm sad that it even got to 2 centimeters without having much bone growth. Usually you recognize that earlier than that. So keep us posted, please.
Yes, please do, Zanza. This question from SGK, is Dr. Paley retiring anytime soon or no? That's a good one.
So first of all, if he does, I'm here, so you're okay. And then we have quite a handful of amazing, talented surgeons that he's trained very well in his image. Not that I know of. He still cranks and goes. I know he has at least 5 more years.
Oh, wow. That's awesome. Yeah. Very cool. The teenage do you have a graph on probability of complication given a certain centimeter of lengthening? So the amount of lengthening.
Paley's published that, and we talked about that. Once you get above 5 centimeters, those rates go up. But how do you define complication? It's a very nebulous thing, and we can go off on whole tangents. And Paley actually wrote an article. There's complications, there's obstacles, and there's setbacks. Is it a trip to the operating room or not? We can get into the nitty gritty. But yeah, the more length you do, the more potential bad things can happen. That's just obvious, but that's proven.
Gotcha. All right, a couple more questions here.
Whether you're experienced or inexperienced, Victor.
What's that?
Whether you're experienced or inexperienced.
Oh, or inexperienced, yeah. Play my little notion there. I got you. You'll find out when I do the video.
I have to get, someone DM and they were accusing me. They didn't use the word collusion, but they were like, you guys talk. Yes, we do. We do talk because we both have a passion to try to get information out there. You may disagree with me, and I'm happy to be told if I said something wrong. Please educate me so I don't make the same mistake. And I certainly don't want to have disinformation. That's why we talked about peptides, and I didn't have much to say, but I said a lot. I don't want to have any bad information out there because I'm very excited that so many people are interested to get more information about this. Okay, but there's our tangent. All right. What do you got?
And we have a disclaimer in the bottom of the video. So, all right. So, so Ben's asking Dr. Craig or Dr. Robbins, in the near future, if there's new internal nails coming, basically he's asking, will the price drop if new nails come in?
That's more of an industry question. It's supply and demand. I mean, there's a certain amount of money that goes into the R&D to make the Max compared to the Precice. I don't know the answer to that. I would guess that as there's a certain threshold where if they're making up a number, if they're making 10,000 nails a year as opposed to 3,000 nails a year, then the cost should come down. Our pass through and cost increase from Precice to Max is dollar for dollar the increased cost of the nail. We're not making more money because we're using a new nail. It's dollar for dollar pass through on our cost, the nail versus the Precice.
Gotcha.
So that's an industry question, but I would assume as if other nails get approved, capitalism and supply and demand, and
basic economy. That's what I thought.
Yeah.
So Ali is saying my femur to tibia ratio is 0.73. I plan on doing 8 centimeters on my femur via the Precice 2. What are your thoughts?
So that's interesting. So the typical range is 80% plus or minus, like 78 to 82. I've measured a lot of x-rays. I mean, a lot of x-rays. And the lowest that comes to mind in someone who doesn't have a known condition, or, I had dietary problems when I was a kid, or I had rickets when I was a child, or, something that happened in childhood, or some genetic problem, is like 75 or 76. 70 is really low. I would be interested in seeing that and seeing how that's measured. That being said, so if 78% is the low end, you're 5% off of 78. I want you, Ali, to look in the mirror as you're lengthening. And when you get to 3, 4, 5, you may decide that, wow, my tibia started short and they are starting to look short relative to my femurs. And I'm planning on 8, but maybe 6 is best for me. Overall height doesn't mean as much because I'm not as happy with the aesthetics of my leg. And so I'm going to pay attention to that. And maybe I change my goal. So there you go. I hope that was helpful.
It's very helpful. Yeah, gives you some strategy. Jam saying, Dr. Robbins, why do other surgeons use a bone stall instead of an osteotome? Does this affect?
I don't know if that's a fair statement. I mean, again, maybe they do. We do. So let's say we're talking about femur, right? So today I broke 6 bones with rods in. So I don't know if you can see that. So what, a centimeter? I can break a femur. Well, it needs to be. It needs to be about the size of the osteotome, which is about 1 centimeter. Yes, using a bone saw. Well, to get a saw in the body means you make a much bigger incision. To get the saw through the muscle to the bone means you strip the tissues off the bone, and tissues bring blood supply. So yes, a bone saw absolutely has an effect, not on distraction. I know that's not what you meant, on healing. Yes, it does. So our percutaneous, minimally invasive bone cutting techniques absolutely have an effect on the bone regenerate and therefore the distraction that you can get.
Gotcha. Okay. He's asking next about contraindications for patients with gout or diabetes for lengthening.
So diabetes in general, first of all, you have bigger concerns than your height. And I'm not saying this to be flippant. Diabetes is a real problem, whether it's type 1 or type 2. So before you go into any type of surgery, you need to work with, whether it's your endocrinologist or your primary care doctor, to make sure your diabetes is dialed in. Make sure your gout is controlled, because anything can flare it up. Surgical is a stressful thing, whether it's elective and you're choosing to do it, or it's post-traumatic because you're in a car accident, God forbid. So complication in patients with diabetes are up across the board for whatever reason. Well, we know the reasons, but in the best of hands, the infection rate, the decreased healing rate, whatever the complications are. God forbid you have a metabolic problem with your diabetes and you fall and then you have a fracture. So please, JM, make sure you are so tuned in with your diabetes and your endocrinologist are on speed dial if you're having a problem, and really make sure that your surgeon and your surgical team know that in the hospital they have your insulin levels controlled and all those things. So it's not an absolute contraindication, but surgical is stressful. And lengthening is stressful. You break your leg and we fix it, then the stress of surgery is gone in a few days, in a few weeks you're recovering. But we're doing that on both sides. And then we're stretching you. So that's stress for months and months. So we have done in diabetic. I'm sure somebody we've operated on has had gout. We've done plenty of patients way in the age range for gout. But stressing the body can make everything flare up. So those are not contraindications, but they sure give me pause.
Gotcha. Very cool. All right. We're going to take probably 5 more questions because we're approaching the 2-hour mark here, and I know Dr. Robbins has to go become Bobby Flay.
Feed the dog, yeah.
Feed the dog.
I didn't cook lentils for Holly. She's gonna come and be mad at me.
She'll like snap your piriformis.
Right. Like, right. You see my wife?
I know, I have.
She's a beast.
She's strong.
Okay, thanks for your answer.
All right, so Darko's just saying, he's just thanking you, and he's saying that the magic sauce of peptides might help out.
Do it and let us know. Absolutely. And then if you don't mind, share how much you're paying for it, how they give it to you, what they're giving you, and why you think it helps. I would love to. Please educate me. I would love to know.
Me too.
Get my email and send it to Victor. He'll send it to me. Reach out to me. Please educate me.
That'd be really interesting.
I don't want to be an old fuddy-duddy and just say, well, we didn't do it before. Why should we do it now? Maybe there's going to be proof and we'll add it to our line of options or have someone who takes care of our pay. I don't know. That's a great thing. So please educate me. I'd love to know.
Yeah. Okay. So the next one from, he says from No Uridan, he's saying, I'm a bodybuilder taking testosterone post-surgery. He's saying, is taking testosterone post-surgery, can it help out with recovery, maintaining muscle mass and power? Also, I'm very flexible and can do splits. Can I lengthen more than average?
So your pre-surgical flexibility doesn't really play into anything at all. In a very general sense, more muscle means harder to stretch. So it may actually work against you. This is going to make you so sad to say, especially if you're a bodybuilder like Victor, who actually works their legs. Your leg mass is going to decrease so much, so fast, you're going to look in the mirror and cry. But I promise it comes back. But you get atrophy of your leg mass so fast. After, not just any surgery, ACL, bunion, whatever it is. So you're going those beautiful muscles you've worked so hard to build are going to go away very fast. And if you got 4 hours in the day, you don't need to be doing push-ups and pull-ups. You need to be on the floor stretching, and splits are great, but splits don't tell me how tight your IT band is. Splits don't tell me how tight your tensor fascia lata is. In general, we've operated on plenty of big guys. And the guy that comes to mind now got over 10 centimeters combined, and his girlfriend stretched him 3 hours a day. He was a beast. It's interesting. He healed one of his tibias much slower than the other, but he healed everything else very fast. But despite his nutrition on point, he was awesome. He just healed slow. But we knew it, and I cautioned him about it, and he was on walker for longer and whatever he needed to do. But he got more length than average and recovered pretty darn quick. So the testosterone is an interesting thing. I have a guy right now who's taking testosterone. He's been taking it for like 25 years. He does his thing, whatever his interval is. It doesn't happen a lot, but I'm not interested in you maintaining muscle mass and power. I'm interested in you maintaining flexibility for lengthening, not just for splits. So it's not an absolute contraindication to stop taking your testosterone, especially because stopping, if you've been taking it a long time, can have a whole cascading effects. So that might require a little more work in a consultation, with you and your surgeon and whoever is helping you manage your exogenous hormone intake to make sure that what you're doing is safe and that you're tapering or whatever you need to do so you don't get into a hormone crisis.
Gotcha. All right. We're going to take 3 more questions here. This one is actually a good one. They're asking, can I, so I have slight bowing on my tibia. Can you fix bowlegs while you maintain simultaneously?
Yes.
He says, here, I'll go to bed and I'll check.
Sure. So we fix deformity in the correction concomitant with lengthening all the time. Say all the time. We do fewer tibias than femurs, but yes, we can absolutely fix the bowing in your tibias if you choose at the time of your tibial lengthening. How do we do it? It takes a little more technique. It takes a little bit longer. It takes a little bit more hardware. But quite literally, when we're breaking the bone to put the rod in, we break the bone and make it straight, and then we put the rod in. And there's some other tips and tricks, proprietary, not going to share. But yes, absolutely, Dave, we can fix your bow legs and lengthen you successfully at the same time.
Cool deal. This is from DACA1, Day 1 supporter. He's saying, checking in with you, Dr. Robbins. He's a satisfied Paley patient veteran going on 4.5 years, so he's just shouting out to you.
Yeah! Love it.
All right, so we have 2 more questions. We're going to take that real quick, and then we're going to call it a day. If you guys have questions, I will post Dr. Robbins' new Instagram in the description after the video, so feel free to reach out to him, and if he has
Yeah.
time, he'll answer them. So Antonio's saying, I noticed on the European Institute's website, it offers the possibility of performing combined lengthening with an interval of 3 weeks between the 2 operations of tibia and femur.
Yep, that's what it is here too. Remember, at the European Institute, there is no max nail for the foreseeable future. And also, I don't go there. It's only Dr. Paley, and he's only there a few weeks a year. So you don't get as much say in when you get it done. You do it when he's there. Also recognize that Dr. Paley is not there for the follow-up. It's our very established, very well-trained colleagues who are in Poland every day, just like I'm home minding the ship when he's there, and when I travel, he minds the ship when I'm gone. That's why you have 2 surgeons. There's almost always someone available, or one of our other very talented colleagues who do this type of stuff. So there's no max nail, and the time slots are severely limited by the time he's there. So you can reach out to Angelique for those dates. But yeah, we do tibias first, and 3 weeks later we do femurs, wherever you're having it.
I think what he was also saying is that they said that if you do it 3 weeks later, on that site it says you can get up to 13 centimeters, but on the American website it's saying that you can only do up to 10.
Then thank you for telling us, Angelique. Victor, send that to her. That's a typo. The chance of you getting 8 and 5, and that is not quite 0, but it's pretty much 0. Yeah, 9 to 10 centimeters is realistic for combined for that protocol where we're doing tibias and then femurs. It is not 13. That's if you do it a year apart.
Yeah, even to have more time. Dr. Robbins is the GOAT. He's done a great job for me. That's one of your patients, I guess. So they're just checking in here. They're giving you shout outs. All right, guys, we're taking the last question. Let's see. I'm going to pick a good one. Who's going to be the lucky one? All right.
We do follow up pretty. I'll look again.
Okay.
We want to do it next week. If you got like 30 minutes, we can hammer out, because I feel bad.
Okay, yeah, that'll be good.
For 2 hours. Yeah, we can find a time next week to do this again.
Okay. Let's see. Let's pick this last one right here. Right here. Okay. So Dr. T-Flux is saying, I have already lengthened my femurs 5 centimeters with a Precice 2, and it's fully consolidated. I'm thinking about finishing the last 3 centimeters, but I would like to switch to P Max. Should I aim for 3 centimeters of lengthening?
So that's a lot of money. It's a lot of money. I mean, you're paying for 2 new nails.
By the nail.
So that's interesting. So then what you're basically saying is it cool to lengthen 10 centimeters in my femurs? Look in the mirror now and see how you look, and that's for you to decide. But I have seen patients with 10 centimeters of lengthening. I saw them because they're having problems and complications from it. But there is a point where just aesthetically it becomes obvious. Now, doesn't mean it's displeasing to you. There are lots of people who are modifying their body in various ways that we might all think twice about doing for ourselves, but it's aesthetically pleasing to them. So the good news is that if you switch nails, doesn't mean you have to even do 3 centimeters. You could do anywhere between 0 and 8. It's for you to decide, and your body may fight back and say, I don't want to do more. But you ask a great question. The guy that I did today surgery on, we reactivated him, and he's only going to be able to get what's left in his nails. So you ask a great question. It's probably biased because we have 8 centimeter nails, and I've been putting them in for so long that you can't get more than 8. But there is a point visually, like when you're sitting and you're looking at your legs, when you're standing up, that it becomes very noticeable. Again, if it doesn't aesthetically bother you, then switch for, and if cost isn't an issue, and if the weight bearing is better for you, if you're able to weight bear on the max nail you get, you do have the potential to get more. Really check your hips before you redo it. Your chance of needing a proximal release is higher, just because you've already been lengthened, and maybe you've consolidated, but we don't know if you've recovered. And if you're going to get more than just a few centimeters, the longer you wait, probably the better chance you have of getting more length, just because your nerves and everything have had a chance to recover. And then just the people in your life that you're leaving to go get this lengthening, they already haven't seen you for 3 months, and then you are on crutches for another 3, 4, 5 months, and then you're just getting back to whole, and then you're going to do it to them again. Like, take a breath, man. Like, be so proud that you got 5 centimeters. And then the question is, you got 5 centimeters and you're doing more. Why didn't you get 8 the first time? All these things are what I think about. So yes, if you change to max, you can get more, but you really got to see how you look when you look at your legs. Do you want to go more? There's no reason you won't be able to get more than 3 because the rods can do more. So
That's awesome.
that's
Very
all
cool.
the things that come to mind when I think about that.
Well said. Well, we're going to let Dr. Robbins go here. So I want to thank Dr. Robbins for coming on and doing this amazing, super informative, valuable live Q&A with Marshall by his side. He's hungry. Look at his mopey face. He's like,
Yeah, I know. He's so sad. Holly's
let him
going to be
go.
the saddest. She's going to be like, tell Victor to stop.
I know.
You're getting hate mail.
Sorry, Marshall. It's all these patients. They want Dr. Robbins' great answers. So thank you so much, Dr. Robbins. We'll have you back on. Again, this is the guy who started the live stream series. If it wasn't for him, Lengthening Live wouldn't be a thing. Other surgeons just, they weren't open to it. He said yes. So we'll bring him back whenever he's available. But guys, pump your love in the chat for Dr. Robbins. And I want to thank all you guys watching from around the world for episode 120 of Lengthening Live. For the amazing Dr. Craig Robbins, I am Victor from Cyborg for Life, signing out. See you guys next time. Peace.
Okay. All right. So, Victor,